Well, maybe we'll get started. Welcome, everyone. I'm Evan Madill. I'm one of the new neuroimmunologists at University of Washington. And I'm going to be moderating a discussion with Dr. Persenaire, who...
Good morning.
Yeah, really great person to talk with about this. Dr. Persenaire has kind of an interesting background after he did medical school at, I think, Wayne State University and neurology residency at University of Colorado. He did fellowship training in cognitive neurology at University of Colorado, and then did additional fellowship training in multiple sclerosis and neuroimmunology at University of Washington. So he's got a kind of unique background and perspective on how autoimmune disease can affect thinking and memory. And I think given his expertise in diagnosing and treating so many cases of autoimmune encephalitis, he's really the perfect person to talk to about all of this. So, Dr. Persenaire, if you don't mind, we start with, for people who are maybe new to the diagnosis, what is autoimmune encephalitis? And under that umbrella term, what are some of the common conditions people might hear about?
Autoimmune encephalitis, if you take that terminology into bits, the encephalitis part just really means that there's inflammation in the brain. And then the autoimmune part is supposed to mean that it's your own immune system which has become confused and is the direct mediator of that, either a damage to neurons or the cause of dysfunction of neurons. So it's encephalitis, since it just means inflammation in the brain. There's many kinds of encephalitis, and infection, for instance, can cause encephalitis. So when people present with signs and symptoms of fairly subacute onset, changes in thinking or personality, and there can be other networks involved, the conundrum is always, is this an infectious disease or is this an autoimmune disease? And so a lot of different diagnostic evaluations are done in order to make that decision, which we'll get into in just a little bit. But once we land on the diagnosis of autoimmune disease or of autoimmune encephalitis, there are several different particular categories. You can divide up the whole category of autoimmune encephalitis in a couple different ways. The way I tend to think about it has to do with, is the cause of the autoimmune encephalitis associated with a cancer or is it not? So I would talk about that in terms of it as a paraneoplastic autoimmune encephalitis or a non-paraneoplastic autoimmune encephalitis. And then the next thing I want to know, is it associated with an antibody that can be detected in the blood or the cerebrospinal fluid, or is it not? And that would correspond to the categories of antibody-associated autoimmune encephalitis or antibody-negative or seronegative autoimmune encephalitis. And then the third thing that I would want to know in the antibody-positive cases are the particular kinds of antibody and whether or not that antibody is designed to recognize as its antigen, an antigen which is on the surface of the cell or on the inside of the cell. So that would roughly correspond to, or that would directly correspond to a cell surface antibody or an intracellular antibody. So that's some of the rough categories of autoimmune encephalitis that I begin to think about when dealing with a case.
So I think a lot of different conditions, obviously, that fall under this broad umbrella of autoimmune encephalitis. I think some of the more common ones people hear about, as you've mentioned, with cell surface antibodies and antibody-associated encephalitis, things like NMDA receptor encephalitis or LGI1 might be terms that people here are familiar with. Seronegative, obviously, when we're thinking about autoimmune encephalitis, where we can't find a particular antibody on our tests that we think is causing the condition. And I guess given that there is this kind of different subcategories of autoimmune encephalitis and so much variability with whether there's an antibody that we think is causing the disease or maybe an antibody but we haven't found it yet, what are some of the symptoms that tend to come up across autoimmune encephalitis in general?
We are also jogging my memory or sparking my thinking about this. When thinking about the particular symptoms which might be caused by autoimmune encephalitis, I also think about particular encephalitis syndromes. For instance, if a part of the brain called the limbic network is involved, which is kind of distributed, throughout the temporal lobes. There's a few places deeper down in the center of the brain that can be involved. The symptoms tend to cluster around memory, mood changes, autonomic symptoms, and can sometimes cause movement disorders as well. And so that's a condition called limbic encephalitis. And then you can certainly have non-limbic-like symptoms. You could have just about any component of the brain which could be harmed and cause a symptom. It could be a weakness or sensory changes or vision changes. Could also be involved. That would be a extra limbic encephalitis, I suppose, although we don't typically talk in that way. And then you can also have your immune system cause damage in the cerebellar networks. And the symptoms can also involve cognitive changes, but tend to cause more discoordinated movement, difficulty with walking, changes in eye movements, and that would be called a cereballitis or autoimmune cereballitis. So some of the symptoms that are rather more specific for an autoimmune encephalitis would be this constellation of changes in thinking, memory, changes in mood. Sometimes people even have psychosis, hallucinations, or delusions in association with seizures and changes in autonomic function. So your nervous system has systems which control like voluntary movement, but there's also systems that you don't have under your voluntary control that affect blood pressure and heart rate. So that constellation of symptoms is fairly unique to an autoimmune encephalitis. So that's maybe the most specific constellation that I can think of.
Great. And, I think that gets to some of the difficulty with diagnosing autoimmune encephalitis. As you've said, the symptoms are ones that we can see in lots of different conditions, encephalitis being inflammation of the brain, and there are other causes beyond autoimmune conditions that can do it. And so I think autoimmune encephalitis oftentimes can look like other diseases, or other diseases can look like autoimmune encephalitis. And that can be difficult, I guess, to parse out. So how do you think about diagnosing autoimmune encephalitis?
So you look at particular risk factors. For instance, if a person has some risk factors for developing cancer, especially lung cancer, that maybe slightly increases the probability. But ultimately, you're looking at not only the clinical syndrome, like Evan said, a lot of things can mimic that, but next you're looking at a brain MRI. The brain MRI can look more or less like an infectious cause or an autoimmune cause. And each one of these syndromes I had talked about, limbic encephalitis or cereballitis or an extralimbic encephalitis, would have different features. So some more specific findings are with the GFAP antibody, for instance. You can see a particular pattern of inflammation in the brain. When you have an MRI done, as an additional component of the MRI to look for active inflammation, you're administered a contrast agent called gadolinium. And so in people that have that particular kind of antibody syndrome or that particular form of autoimmune encephalitis, the post-gadolinium contrast enhancement takes on this very unusual pattern. So sometimes on MRIs, you see some specific findings that let you know you're on the correct trail. Beyond looking at an MRI, because you can certainly have normal MRIs, unfortunately, in autoimmune encephalitis, which makes it even more difficult, the next step is to look at cerebral spinal fluid. When you sample cerebral spinal fluid, you're really, you're looking at the components of the fluid that bathes your brain. So it's almost like a biopsy. I mean, it's a fluid biopsy. It's not the same as seeing actual neurons. But by examining the fluid, you can establish whether or not there is an abnormal activation of the adaptive immune system behind the blood-brain barrier in the intrathecal compartment. We look at cell counts. There's an established diagnostic criteria for possible autoimmune encephalitis, which most people will meet. And that involves looking at cell counts, seeing an elevated lymphocyte count or an elevated immune cell count in the cerebrospinal fluid, and then also looking for these proteins called immunoglobulins, they really are antibodies. But you can see that there is an abnormal production of a select set of antibodies or immunoglobulins by using a test called the oligoclonal banding test. So those are some features that we look for in the cerebrospinal fluid. And then I think probably I would say the fourth most useful test, and I'm thinking of the clinical history and syndrome as a test here. The fourth most useful test would be an EEG. If you see asymmetries in the EEG, or if people are having subclinical seizures, that can help differentiate an autoimmune encephalitis from principally a non-inflammatory disease process. So you could have seizures even if you're having like an infectious encephalitis, but sometimes what people actually have is what we would traditionally think of as a primary psychiatric disease, and we are not expecting those individuals to be having seizures or changes on their EEG.
I think you're getting to the criteria that you mentioned there, because this is such a difficult diagnosis to make for a long time, maybe gotten a little bit easier as we've had some more antibodies that have been found and we have the ability to test specifically for these antibodies, but certainly still can be challenging. And so there are some guidelines on how do you make a diagnosis of autoimmune encephalitis. And as you're saying, it's having symptoms that would fit with inflammation in the brain and really seeing those symptoms evolve, I think, over weeks and months, as you've said, as opposed to maybe memory changes that happen gradually over months and years, or symptoms like weakness that happens 1 second to the next, where we might think more about a stroke. The kind of tempo of inflammation in the brain and autoimmune encephalitis, you really expect to see memory changes, seizures, trouble with coordination, these things changing over weeks and months, and then expect to see some signs of inflammation on some of the testing that we're doing, whether that's spinal fluid testing or on an MRI, maybe signs of irritation and inflammation on an EEG as showing as seizures or subclinical seizures. And then can we detect potentially one of these now recognized antibodies either in blood or in spinal fluid? And I think maybe just one point of caution there from my own experience is that where the test is sent really matters. And so there are quite a few companies now that will offer to test your blood or your spinal fluid for kind of every antibody under the sun, and they can come back falsely elevated sometimes. And so I think the location that the test is sent to matters, and also having symptoms that really fit with the antibody that comes back positive matters for making the diagnosis. But if we're seeing signs of inflammation, spinal fluid, MRI, EEG abnormalities, or finding a positive antibody that really fits with a known condition, known symptoms of that antibody, I'd say that really helps to clarify the diagnosis.
That's an extremely important point. If you just took everybody that healthy people or people that had symptoms that were unlike autoimmune encephalitis at all and did these antibody tests, you would find autoantibodies in a surprising number of people. There have been studies showing that in a poorly selected patient population, by I mean poorly selected, I mean these antibody tests were sent in cases where they probably should not have been tested. You're actually mostly finding false positives. You're actually you're detecting antibodies that are not causing a problem or connected with the problem in these folks.
I guess if there is a established diagnosis of autoimmune encephalitis, or if we have a fair amount of confidence that that's what's going on, how do you think about treatment as next steps?
I sometimes talk to I think about this in these terms myself, but when I'm talking to our residents, I have two kind of imaginary statistical probabilities, and oftentimes we don't actually know the probability, but I have a threshold that I would use to say, this is my threshold that I would say is my threshold to diagnose. So how certain would I have to be of a diagnosis to say this is what the person has? You know, I'm something like confident that the person has this diagnosis. And then I also have my threshold to treat. These thresholds are actually different. How confident would I have to be in order to recommend treatment for this condition? Because the treatment of autoimmune encephalitis, in many cases, is more effective when given sooner, and here even weeks matters. And it can take some time to gather some of these test results. The antibody tests sometimes don't come back for a few weeks. So if I am seeing somebody with a constellation of symptoms that are very much like what I expect for an autoimmune encephalitis, and I have MRI findings consistent with an autoimmune encephalitis, the first thing, the one thing, thankfully, we can do is we can rule out an infectious encephalitis fairly quickly by looking at the spinal fluid, finding out whether the person has an infection elsewhere in their body. There's some specific infections that you can test for, but the results come back fairly quickly. I want to see those tests come back negative, so I think I'm not dealing with an infection. But if I'm not, then my threshold to treat for an autoimmune encephalitis will have been met in a case like this. So I'll actually move on with using immunotherapies, maybe steroids or IVIG, rather than waiting for the antibody test to come back. This whether I take that approach would also be modified by how severe a person's symptoms are. If they were, in the hospital and I was able to keep a close eye on them, their symptoms were, very mild, then I might recommend waiting for some of these things to come back. And in cases where that threshold to treat is not met, in those cases, I will wait for additional information to come in because I'm just not certain enough that the person has this specific disease process in order for the risks of the treatment. This decision to use these treatments has to be modified by how dangerous the treatments are as well. I'll wait for additional information to come in if I think that the probability of the diagnosis is so low that at this point it's just the risks outweigh the benefits of moving forward with treatments that the person may ultimately prove not to need.
That's a good point. I think one of the challenges is balancing, right, the goal to treat early and to prevent or stop the inflammatory process in the brain, prevent damage, and weighing that against the toxicities of some of these treatments and how certain do we want to be before we think about using an immunosuppressive treatment. And I think you made a good point there with, the time course and the symptoms can be very helpful. We talked about autoimmune encephalitis being an umbrella term for a lot of different conditions. And there's kind of a spectrum of how they present, as you said, some with very serious symptoms of blood pressure changes, seizures, things that are kind of going on over days and weeks and may land someone in the intensive care unit, and sometimes much more subtle memory changes that might come on over months and something we would see in the outpatient clinic even. And I think the treatments there might depend on kind of how quickly things are changing, how severe the symptoms are, and how do you balance that risk-benefit consideration. All of our treatments really are immunosuppressive, I think, to some degree, and so it's certainly not, benign to just say, well, let's try this and see what happens. And I think also gets to one of the difficulties with treatment where a lot of people with various conditions feel better if they get steroids. Even if the steroids are not treating inflammation, it can sometimes give a boost to energy levels, give a boost to just how people are feeling in general. And so it can be really hard to use a treatment sort of empirically and say, well, someone feels better, we must be treating an autoimmune problem. Can kind of get yourself into trouble then when we start thinking about, do we need to escalate beyond steroids to kind of longer term immunosuppressants, because we know steroids have a lot of side effects over the long term. And I think that can often be quite challenging, but the presentation with how severe symptoms are and how quickly things are changing can help guide that discussion.
And we also use steroids sometimes in people who we know have brain infections. There's some evidence that that can help certain kinds of brain infections. The reason I bring that up is because in those cases, people will feel better as a result of the influence of steroids on neurons, but also just as an anti-inflammatory effect. And then I've also seen cases where people who ultimately did not have autoimmune encephalitis and had what was probably a severe depression get steroids, and that also seemed to actually improve symptoms of depression in those cases. So like you pointed out, a response to one of these treatments is not functioning as well as you might think as a diagnostic test. There's other situations, there's other illnesses where somebody could have where you'd say like, well, let's give this treatment, and if they really respond well, then probably they have the illness that the treatment was meant to target. It doesn't quite work out as well in autoimmune encephalitis.
And that gets challenging as well, because I think a lot of times we're considering treatment for fairly long periods of time. This is not just getting steroids in the hospital. People look better and kind of go out on their way. I think a lot of times people are coming into the clinic over the following years thinking about, do they need a long-term treatment to replace steroids over 2 or 3 years, potentially even longer? How do you think about how long to treat for, and knowing that it's variable based on which specific condition we're talking about, but there's some general principles there.
That's the main thing. If you this gets some of the most difficult situations are when people have like a seronegative or antibody negative autoimmune encephalitis, and there's just not as much evidence as you'd want to know that that diagnosis is correct. It's not as though you've been able to make an alternative diagnosis, but maybe there's an incomplete response to treatment. And then the thing that causes me to lie awake at night is the idea of how far do you escalate these immunotherapies? Because there are some immunotherapies that can be used that increase long-term risk for cancer and put people at risk for infection. So there's some harm that comes along with these things. So there's diagnostic categories where the outcomes are just so variable that there's really no good track record or evidence to know whether or not a long-term treatment is needed. On the other hand, there are conditions where the features of that specific autoimmune encephalitis are specific enough. As an example, the LGI1 encephalitis. That diagnosis has features such that when you see that particular constellation of symptoms, memory loss, this particular kind of seizure that they get along with this antibody, we have more cases in the literature, and we know what to expect long term, and you can use that kind of information in order to predict. If we just treat the acute illness and we don't continue treatment, here is the probability that the person will relapse. You can learn that number from the literature. That helps you make a decision about do the risks outweigh the benefits. There's other situations where people have a form of what I would consider an autoimmune encephalitis, acute demyelinating encephalomyelitis, or ADEM, where we actually expect that to be a monophasic illness. You treat the acute phase, and the recoveries can be extremely good. And we know in those situations that people are not going to need a long-term treatment. The risk of having a relapse of something like that is too low to justify that.
Glad you mentioned recovery, because I think that's another thing we should think about talking about here. Again, maybe some general principles that this is really an umbrella term. Symptoms, treatments depend a lot on the specific diagnosis, if we can get to a particular antibody or just this seronegative autoimmune encephalitis group, but really trying to break down autoimmune encephalitis into particular subconditions, and then assuming we recognize one, we feel pretty confident about our diagnosis, we treat correctly. What does recovery tend to look like?
The recovery is different for different cases of autoimmune encephalitis, but when the brain has an inflammation, I would be when I talk with people who are experiencing this or after they experienced it more likely, I like to hear people's ideas of what picture do they have in mind when they're thinking about inflammation. Because inflammation is actually quite complex. It is in some sense, an abnormal activation of the immune system, but sometimes that inflammation is not actually leading to neuronal injury and neuronal death. It's also changing some properties of the microenvironment around the neuron, such that the neuron is dysfunctioning, but has all its normal elements that would allow it to function normally. And then in those cases, if you use immunotherapies, especially steroids, you can fix those problems fairly quickly, and people can have a rapid improvement in symptoms. I was talking before about how sometimes the inflammatory attack is not actually injuring neurons. Sometimes it's just causing a receptor on a neuron to dysfunction. Sometimes it causes the neuron to change the number of these receptors on its cell surface, where the neuron is actually, survived. And if you get the inflammation out of the way, it can repair itself and can then go on to function normally. So that's why in some cases the outcomes can be extremely extremely good. But in many cases, you start to see improvement over just several days and a few weeks. There's other specific kinds of autoimmune encephalitis, NMDA-AR receptor encephalitis, where the recovery can actually take quite a long time. But in those cases, people can have really good outcomes as well. So even though they look like even though it looks like their brains are really struggling, if they stick with the treatment, they can have fantastic recoveries. And then, unfortunately, there are cases where the nature of the inflammatory attack is harming neurons in such a way that we just don't have very good tools to put a stop to that inflammation. Sometimes the thing that has provoked the immune system to cause this harm is in the body in such a way, maybe connected with the cancer, such that our tools are just not very effective at rescuing the brain cells from that kind of inflammatory attack. And in those cases, unfortunately, sometimes the symptoms we can maybe get to stabilize, but they can continue and even become permanent without recovery. So the pace at which people recover and the long-term outcomes is really all over the board. But it is helpful to know the specifics of the case.
Yeah, absolutely. Yeah, variable, I think, keeping with our theme of the symptoms and the treatment being variable, but certainly surprising to me when I was learning that the recovery for NMDA receptor encephalitis can be years after someone first has symptoms, and so there really is kind of expect to see improvement even 2 or 3 years later, unlike some of the other neurological conditions maybe that we're more used to seeing. I think we're running a little short on time, so maybe just one more question for you, and then we'll open up to other questions from the audience. What are some resources that you think people would benefit from knowing about for autoimmune encephalitis in general? Or are there resources you share with your patients that you think would be helpful to know?
In terms of treatments or in terms of education?
Education, support systems.
Well, I think the Autoimmune Encephalitis Alliance website is a fantastic repository of information. I know that they connect people with other individuals who have had similar conditions. They actually include references to some of the landmark publications or some of the most important publications on the topic if you want good, solid information. They do come in the form of scientific manuscripts that can be a little bit hard to interpret. And they also help connect people with resources in their local area. They can let you know of any particular neurologists who have seen more cases or bill themselves of having any kind of expertise. In the University of Washington specifically, in the Seattle area, there's a few neurology clinics, but especially the University of Washington Neuroimmunology Clinic or Multiple Sclerosis Clinic. We have a really good set of resources to help people with these kinds of conditions. So, do you have anything to add to that in terms of typical resources you use?
Oh yeah, I think plugging University of Washington is not an expectation, but it's a good point that there's a really great rehab medicine and rehab psychology group here, and I think those folks can be really helpful. Like, getting to some of the benefit of having an interdisciplinary team. The importance of seeing other folks beyond just a neurologist. A really good group of physical therapists, occupational therapists. There's some people who specialize in returning to work after autoimmune encephalitis, dealing with some of the psychiatric symptoms that can come along with it. So it can really help, I think, to be at a center like University of Washington or maybe just a larger medical center with some experience with autoimmune encephalitis because of all these other specialties and resources that you can draw on.
There's a few universities who maintain websites devoted to all kinds of neurologic conditions that are they tend to be pretty broad. They don't necessarily go too deep on any one particular topic. But I'm thinking of places like I know the Mayo Clinic is one. I think the Cleveland Clinic is another one. Maybe Hopkins. But I'll often turn people's attention to those websites because I think they don't go so deep. They keep it broad because they want to be able to say things that they know are true rather than going into more nuanced perspectives where we're not quite certain of our knowledge on the cutting edge. But they definitely give you the basics.
The time we have left, if anyone has any questions that they'd like to, yeah, go ahead. Sorry, in the back row, yeah.
You mentioned prednisone and also the immunoglobulin as two of the treatments, and the risk are possibly cancer or infections and things like this. I don't know if you mentioned rituximab or similar antibody suppressants. If you could just elaborate on that just a little bit.
Sure, yeah, and maybe I'll just restate for, I think, folks watching from home. So the question was about treatments like rituximab or Rituxan specifically, and maybe what some of the risks and benefits would be there.
I think of the treatments in a couple categories. Trying to think of whether or not these are actually bright lines between these categories, but there's the acute treatments. By acute, I mean these are the treatments that you give right up front to try and put the inflammation out. And then there are the more chronic set, the set of treatments that you'd use on a longer term basis that are meant to try and keep the inflammation at bay and try to prevent recurrences. Rituximab actually falls into the border zone of those. In terms of the treatments that you use right up front, I would say that there are basically there's a treatment algorithm where you're kind of escalating depending on whether or not you're getting a response or how severely ill the person is. Right up front, in most cases, if the person will tolerate it, is going to be some form of a corticosteroid, either prednisone or solumedrol or dexamethasone, which works in a fairly complex way, given it is a steroid hormone. Then you have intravenous immunoglobulin, or even subcutaneous immunoglobulin, most of the time intravenous immunoglobulin. And then you also have a procedure called plasma exchange, or apheresis, which is a little bit like dialysis. Those three treatments are almost complementary. They're oftentimes not all used, But quite often we're using steroids and IVIG or steroids and plasma exchange. And there are some conditions where you want to use both of those in fairly short succession. In cases where people are not responding to those treatments, that's when you might move on to something like rituximab. I could probably go on for 20 minutes about just rituximab, but rituximab is a medication which selectively eliminates a subset of B lymphocytes, a kind of immune cell. It takes them out of circulation, and that actually has a fairly interesting set of effects on other inflammatory cells. But because it is eliminating a component of your immune system, and your immune system will stay like that for a long period of time, there is an increased risk of infections when that happens. It's not a very high risk, which is good news, but that risk is there. And then I don't know how long I should go on about this kind of thing, but you could name, you could go on and name 10, 15 different immune suppressive medications, which all have idiosyncratic side effect profiles and different impacts on the immune system.
Yeah, no, I think that's great. Maybe we can move on, but I think the point's well taken that
Did that answer your question? Okay.
Yeah.
Okay.
I think certainly lots of different treatments, broadly infection being a big concern when we use them, but if we pick the right treatment, a lot of benefit there where the benefits are outweighing the risk. So yeah, sorry, I think you had a question next.
Well, first I want to say thank you to Dr. Madill and Dr. Persenaire for your
Of course.
presentation today. And I really appreciate, so just to introduce myself really quickly, I'm working on the research team with the Swedish Foundation. And as I'm thinking about your discussion about differential diagnoses and treatments for autoimmune encephalitis, I was wondering if you could talk more about when you use immunosuppressive therapies, the risk of things like hypogammaglobulinemia as it relates to immunoglobulins in the patient. When you're taking immunosuppressive therapies, the risk of opportunistic infections, general infection as it relates to the therapy that they may already be taking, and how you're thinking about things like immune tolerization, both within your clinical care and research when it comes to that. So how are you like balancing those two things when it comes to immune response?
Yeah, it's a really good question. And again, getting to risks with the treatments, you're saying hypogammaglobulinemia infections, and maybe some of the treatments that are coming down the road from the research side, immune tolerization, and that sort of thing. I don't know if you want to jump in there. I'm happy to.
I'll try and
as well,
tackle those things. I'm going to repeat some aspects of the question. I'll try and take them one at a time. One was the specific risks of hypogammaglobulinemia. You gave that example, which just to define what that is, I mean, you have a number of circulating antibodies, immunoglobulins. They come in different varieties, A, G, E, M, and we know about the concentrations in the bloodstream for a healthy adult, how many immunoglobulins you should see. Hypogammaglobulinemia refers to this IgG portion of the immunoglobulins. When you suppress the immune system, not every immune suppressant would have this effect, but you could see it with long-term use of steroids, and then you quite prominently see it when using a medication like rituximab. And the reason for that is known. The specific the kind of B lymphocyte that rituximab is taking out of circulation is the kind of lymphocyte which, I apologize, is the kind of lymphocyte which would mature into the kind of immune cell that produces immunoglobulins. So you're depleting this population of cells that produce these immunoglobulins because you're depleting the precursor cells. So over a long time, over the first 6 months or a year of use, you can expect to see a drop in immunoglobulins. Oftentimes it's only around 26% or so, 25% of the amount, but that continues to go down with long-term use. As your immunoglobulin levels drop, there is an increasing risk of infection. We don't know this so well in autoimmune encephalitis populations, but this medication, rituximab, is used for rheumatologic conditions. It's used very often in multiple sclerosis and in lymphoma for shorter periods of time. So that's why we know so much about the particular use of that medication. We monitor for this complication, and if people are having frequent infections and low immunoglobulins, we can sometimes supplement those immunoglobulins, or we recommend that the treatment be stopped and replaced by an alternative that wouldn't be associated with decreased immunoglobulins. Second part of that question, I've already forgotten.
Thank you for discussing that. I guess my other part of the question was about immune tolerization. So thinking about autoimmune conditions, specifically autoimmune encephalitis, but really more generally when it comes to making sure or providing medications that allow the immune system to not have as much of an autoimmune attack and function more as it should. Are there ways that you are approaching that within your clinical care with the medications that are already approved or might be off-label, or is that like a research question long-term?
Yeah, it's a good question. I think to some extent it's still a research question, certainly, but there's a bit of a spectrum on how close medications are in trials and in the lab to ending up in the clinical setting. I think you're right to bring it up because a lot of the treatments we talk about and a lot of the old treatments for autoimmune conditions suppress the immune system pretty broadly. And a lot of the newer treatments that have come out are much more targeted at trying to suppress a specific part of the immune system that we think is driving the condition and whatever it is, whether it's B cells or targeting particular antibodies and parts of antibodies that we think are causing these conditions. And that's really the goal, because I think autoimmune conditions in general and autoimmune encephalitis is not necessarily overactivation of the immune system. It's maybe more dysregulation of the immune system. And if we just suppress the immune system, you do get the benefit of treating the autoimmune condition, but you also get the risk of infections and side effects there. And so if we can more specifically target the dysregulated part of the immune system or try to bring the immune system back into more of a balance, then presumably we'd have less infection, fewer side effect risks, and get the benefit there. So,
we try to mitigate some of those infections with vaccines is one strategy for viruses that establish latency in the body, varicella zoster, for instance, other vaccines.
Dr. Madill, you mentioned about steroids being better in sugar. I know each individual case is different, but can somebody who has lost a sense of smell when you use steroid, it comes back, and when you taper it goes away, the blood pressure, heart rate is high, medication is there, it comes down, so you should stop it. Stiffness goes away, your nasal discharge when you tested for allergy, which is negative, it goes away. Eye discharge goes away, itching goes away.
Yeah.
Twitching, onset, legs goes away. Is it like pointing towards some immune condition or something? Can you take it?
Yeah, it's a fair question. Does improvement with steroids point to there being an underlying autoimmune cause and across a variety of symptoms? And I guess I would say for some symptoms it might be suggestive, but I think there are other symptoms where people feel better with steroids that are not necessarily mediated by an autoimmune cause, and fatigue being one of the big examples that we think about where steroids can kind of boost up energy levels. And so if someone feels like their energy is quite a bit better once they start taking steroids, that doesn't necessarily tell us, oh, this is an autoimmune encephalitis that's causing the fatigue or an autoimmune problem.
Headache is the same way.
Yeah.
People who have migraine headaches refractory to treatment will sometimes also be prescribed steroids.
Yeah, exactly. So, I think you, again, maybe want to get to the risk benefit of using some of these medications. And we'd say, well, if you're taking, a short course of steroids for a sinus infection outpatient, that's a pretty low risk, right? But if you're using high doses of steroids like we would use to treat autoimmune encephalitis, and you're using them over longer periods of time, that's really where we start to get concerned about a lot of these risks. So I think the response to steroids doesn't always help you, but certainly if we're talking about people who are in the ICU with seizures and kind of severe movement disorders, severe blood pressure changes, and we're seeing improvement with steroids there, that might be much more suggestive. Yeah.
So can steroid lead to improvement in your sense of smell?
You know, I think that certainly could be the case, maybe through some different mechanisms if you had an autoimmune condition, potentially, right? Potentially just if you had severe sinus infection and inflammation could, you know, dampening down some of the...
Underlying allergy, nothing like that, and suddenly you can't smell and
Yeah, there's lots of questions like that where I think the answer would have to be like, could it? I'd say conceivably it could, but is there a causal relationship between we did this and then this happened in any one specific case? I get annoyed when people say it's more difficult, because more difficult sounds like if you just tried harder you could. What I mean to say is impossible. It is in some cases it is impossible to know with certainty or even very good confidence whether or not there's a causal relationship. But there's various situations where you'd say, you know, we did this was the outcome. I just can't conceive of how what we did was not in some way causally related to the improvement in symptoms. But that's as far as the reasoning goes in a lot of cases.
Yeah, and I think that maybe gets back to we want to see some other signs of an autoimmune condition there with other symptoms that we know are very closely linked to autoimmune disease or signs of inflammation on, you know, MRI or spinal fluid, something that gives us confidence that using these treatments with side effects over longer periods of time is really beneficial. Other questions? Yeah. Right. Yeah. No, I think it can be very hard to know. And sorry, I'll restate the question again. You know, if you have had kind of a severe autoimmune encephalitis, something like NMDA receptor encephalitis, you've also had brain swelling, maybe and brain injury that happens. How do you know what is perhaps symptoms left over from the initial injury versus a relapse of or kind of signs of ongoing inflammation from NMDA receptor encephalitis?
That's is an extremely difficult question. Some of the things that I have found useful, and I can't claim to have this totally sorted out, but number one, we do have some tests that tell us about inflammation rather directly. MRIs being one of them, gadolinium enhancement, or even some of the non-enhancing abnormal signal that you can see. You could see, like, if there's like actual swelling, you can actually see that on an MRI, as opposed to the consequences of that injury, which may be sclerosis and atrophy. So if a person continues to have symptoms and I do an MRI, and instead of seeing swelling and gadolinium enhancement, I see sclerosis and atrophy of the tissues that have been damaged, then I feel pretty confident in saying that what we're actually dealing with here is the chronic consequences of that injury rather than an ongoing inflammation. You can also retest the spinal fluid and find out, is there actually active inflammation still in the spinal fluid? And then one phenomenon to be aware of is anytime the structure of the cerebral cortex, where most of the neuronal cell bodies are, is injured, and this happens from almost any kind of brain injury, traumatic or inflammatory or stroke, there is a chance that the person then goes on to develop seizures. And the seizures can be a recurrent phenomenon that are associated with, sometimes additional confusion or memory side effects or emotional changes. So seizures in particularly, when they recur, that's a conundrum where I'm often relying on repeat cerebrospinal fluid testing or MRI to find out, is this seizure being caused by an ongoing inflammation, or is it the consequences of an inflammation which has now been adequately treated in the past?
Yeah, and I think to Dr. Persenaire's point earlier, the time course of symptoms really helps you. It really is one of our tests. And we talked about wanting to treat early to prevent injury, but this is a little bit different from, say, a stroke, where we'd tell you should get to the hospital immediately. We want to, break up this blood clot. I think this is really autoimmune encephalitis conditions where we'll see changes over days and weeks. And so it might be the case where, if you're wondering, is this old damage left behind or is this a relapse? Seeing how things change over the coming days can be helpful. If you're seeing things are really ramping up and getting worse, that might make us more worried about a relapse. If you find that the symptoms you have are just kind of stable and what you're left with after getting a diagnosis and treatment, that might point more to just the chronic injury or the scarring that's left behind. Yeah, it can be both, I guess. So the question was, what types of seizures do you see? And usually what you will see are focal seizures, where there's some evidence of brain irritation that sparks into a seizure coming from the area of prior inflammation or scarring, right? And sometimes those focal seizures can spread and cause a generalized seizure. So you could see both. But a lot of times, if we're looking on an EEG, we'll see, signs that it originated from one of these areas of scarring or inflammation. Mm-hmm. I think we're probably running up against time, so I want to let anyone who needs to go to the next session go, but I'm certainly happy to stick around and answer more questions. And
Me too.
I think.
I know there was one more question here, and then we probably should move on because we have the panel with caregivers.
What time is the panel? Do we know that?
It was supposed to start 15 minutes ago, but we can stop this conversation. This is such a good conversation.
It's my fault. I had
Anybody
the
who wants
timing
to go
wrong.
to the
Sorry
panel,
about
you
that.
are dismissed. Sorry.
I was in charge of being a timekeeper, and suddenly I thought, was it me? So I thought,
No, it was probably me, and I probably did a bad
probably-
job. Sorry about that.
Terry's hand kept going up, so I want to get your question in, and then we will shift to getting different people sitting up here. Thank you guys so much for all
No, my fault.
Yeah, so, thank you very much. And I just want to say that, one spot that was difficult for us was the bridge between finding out Kent was having these, symptoms and then going through the normal path, and the bridge between going to the doctor with all these weird things happening and then getting to people who finally knew what was going on. Like all these tests you talked about first, like determining out. It was a long time between when things first started happening, seizures started happening to get to those people. What outreach, education, informing, GPs or even epilepsy centers about
Mhm.
is happening so that people get treatment as quickly as possible?
I don't know that I know the answer to that question. I know that there are patient advocacy groups, again, Autoimmune Encephalitis Alliance, which definitely do a pretty good job with that. All clinicians, all people who are involved in diagnosing and treating any kind of medical problem, it is mandated that they have a ongoing update in their knowledge, continuing medical education. And so they will have to read journals, attend conferences. That's another method by which that is done. I don't know if that's happening. I don't know how much autoimmune encephalitis is coming up in emergency department, emergency physician conferences or primary care conferences. But I definitely see it more and more at neurology conferences. And I also attend some neuropsychiatry conferences where this topic is coming up over and over again. So I would say within neurology and in psychiatry, autoimmune encephalitis is something which is certainly known about and more. So the new generation of physicians in those specialties, I think, will be relatively familiar with autoimmune encephalitis. Not as familiar as people who are in the specialty of neuroimmunology, though.
Yeah, I think you'll find that knowledge dissemination in medicine is always slower than we want it to be, right? But some of the criteria that Dr. Persenaire was talking about with helping us to better recognize conditions like autoimmune encephalitis, even if there's not an antibody we can point to. The criteria just came out 9 years ago, which sounds like a long time, but that's sort of one generation of new physicians coming through training. And so I think there will be more and more recognition as people train now in this world where we have a lot more antibodies to point to and a lot better kind of understanding of autoimmune encephalitis. But I think a lot of the work that's been done by patients has been really helpful as well with books like Brain on Fire and movies that have come out, and that really kind of brings some of the stories to maybe public consciousness more than our conferences and training with the neurology residents, disseminating some knowledge to their emergency medicine counterparts and all of that. So
I have something controversial to say. Maybe younger doctors. But I think that we are eventually headed, I don't know when this is going to happen, but I think this is going to happen in my lifetime. I think we're eventually headed to a day where there's a microphone listening in on a conversation. MRIs are automatically evaluated along with laboratory tests, and maybe even video footage is looked at by an artificial intelligence system, and it's not that the artificial intelligence system then takes over and is the doctor, but then it would kind of act as saying like maybe we should think about autoimmune encephalitis, or maybe we should think this person could have this rare disease or something like that. It might be pinging a doctor's brain to at least consider that possibility. My guess is that will be happening at some point. I want that to happen. I think that needs to happen, just like we need to have self-driving cars. I think that would be a big improvement. Of course.
pleasure, yeah. All right. I know Dr. Persenaire is working in the hospital today on call, so maybe
Yep,
you
gotta
might
go
have
back to
get
the
out of here,
hospital.
but thank you all so much.